talking on is a very, very important topic in today's scenario, and that is on obesity. Uh, in India, we are having what we call as the double whammy as far as nutrition is concerned, because we have malnutrition. When we say malnutrition, we usually talk about protein energy malnutrition and stunting and all those things, but we forget that malnutrition is also obesity. So in our country, we are having both the things together at the same time, which is a very peculiar kind of a affection, because a lot of our children are stunted, and quite a few of our children, school going children from middle class, are obese also. So to touch upon the two topics, we have got this galaxy doctor of speakers and stars. Dr. IPS Kocher is senior consultant and in charge of endocrinology and metabolic disorders in the Prastar Apollo Hospital. A well-known personality and close friend, and the speaker is going to be Dr. Meenal, who's in Jaipur and is a practicing pediatric endocrinologist and senior consultant at Fortis, Jaipur. Na? Is that right, Meenal?
No, sir. I'm at Manipal Hospital, sir.
Okay, you are at Manipal also. Okay, thank you very much. And I think Dr. Kocher, with your comments first, we would like to start the topic. Dr. Kocher.
Thank you, Anupam, and for inviting me as a chairperson. So this is a very important, condition which in the rural population and the urban population. So that reason they have changed the name of this. It's called as ABCD. ABCD means that patient has got adiposity-based chronic disease. So they're trying to remove this, this name of obesity and change it into ABCD. Two reasons. One is that people get more aware of the chronic, and it is not like a stigma, obesity, calling someone. So that is there. And third thing is there, there are a lot of compliments with Dr. Mehal. She will talk about it more. So I hand over to Dr. Mehal, and we'll have the question answer session after the end. So I please, Dr. Mehal, carry on with the talk.
Thank you so much, sir. First of all, I'm obliged to Dr. Anupam Sachdeva sir for inviting me on this platform and introducing me to all the DNB residents or the pediatric residents of Gangaram. And then secondly, of course, Dr. IPS Kocher sir, who has always been very kind to me, and he has invited me almost every year in the Growth Hormone Symposium to Delhi. So thank you so much, sir, for chairing my session today. So the topic that we are going to discuss today is childhood obesity, as it has been assigned to me. So because it's for the students and for the general understanding, I have made it case-based. So let us see how we can proceed with it. Kindly, with your permission, sir. So let's see. A girl, Isha, she's 5 years old and presents to a general pediatric OPD with cough and cold. Coming from a happy, well-to-do family, she's the first child in the family, most pampered and overfed with calorie-dense food. Now, parents did not even mention that the child is obese or overweight. They just came for a routine visit of cough and cold. I tried, or you tried to draw the attention towards the chubby child or the overweight child or the overfed child. And the parents are not very happy to discuss the weight of the child because they don't think that the child is overweight or obese, or they don't even know that obesity or overweight children is a diseased condition, is a disease in itself, or maybe it is a progenitor of most of the metabolic disorders. So they are a bit surprised at my attitude of drawing their attention to the overweight child. So the question is, are we overemphasizing obesity? Is it just a cosmetic problem? Or are we doctors really right in drawing the attention towards the weight of the children? So we have to make parents and the families understand what does obesity in childhood mean and where is it leading to. Number one, it can lead to all the metabolic complications. As we understand, it is the progenitor of type 2 diabetes. It can lead to precocity. It can lead to, in girls specifically, to PCOD. In boys, we can also have hypogonadism, infertility. Then we can also have all the cardiovascular complications which can happen at early age, and specifically in Asian ethnicity, we know that most of the metabolic complications, they set in a decade earlier. Then there are social and psychological problems, like the child is isolated and left alone. There are body shaming problems, and that leads to depression, anxiety, drug abuses, and social isolation. Then there can be gastrointestinal problems, there can be renal problems. There is OSA, very, very important. And of course, there can be some neurological disturbances also. And not to forget, overweight child will always develop weaker bones, weaker joints. There can be slipped capital femoral epiphysis, or there can be even osteoporosis. So now, how do we diagnose pediatric obesity, or how do we actually label that, yes, this child is overweight and we need to focus on the weight of the child? So to diagnose obesity in children, we have standard growth curves, growth charts. Below 5 years, we are using the WHO charts, and after 5 years, we are using the IAP charts. So these charts are very specific for weight for height, also giving the BMI indexes. They are very clearly for the boys and girls. They are separate, the blue for boys and pink for the girls. Then by definition, if we go, so any child who's having a BMI less than 5 years, we are talking. So if the BMI is more than 2 standard deviations, that child is overweight. And if the BMI is more than 3 SD, it is obese. If the child is presenting to us after 5 years, then we go by the IAP charts. And if the IAP charts are showing that the BMI is more than 85% as the standard of age and sex, then it is overweight, and above 95 percentile, it is obese. So this is another way of defining obesity. Now the parents are concerned. Now the parents want to know more because you have told them what we are thinking. We are thinking futuristic vision. So now they are ready to talk about weight, and for the next visit, they come specifically to talk and discuss the weight of the child. So this is the time that we doctors need to detail into the history taking. So now comes the topic of history taking, that what do we need to understand when we are dealing with an overweight child or obese child. So first of all, we need to draw the attention that is this new onset or is it something that has been happening since long? So the duration of obesity becomes important. Then the progression, like how rapidly the child has been gaining weight. That is important, that to understand how rapidly the child has been gaining weight, and is the school performance deteriorating? So is this affecting the cognition? Then we need to know the obesity history in the family. Like, is everybody in the family obese? Is it coming genetically? Or is it because nobody is running in the family? That is it lifestyle based? Also, we need to know the complications that have already happened in the family due to obesity, like cardiovascular diseases, diabetes, hypertension, and other lung problems. Then we come to the specific medical history of the child. Specifically, what we are interested in knowing, that is the child on steroids for some reasons or any antipsychotics for some reason, because both the groups of drugs are known to put on weight. Then we need to know the screen time. And when we are talking of screen time, of course, nowadays everything is on screen. Even our meeting is on screen. So we are specifically focusing on the non-academic screen time. Then the physical activity, how active the child is, how much time the parents are giving to the children in physical activity, spending time playing with children. What pattern of diet the family is following, because the family eats together specifically. And are we pampering the child with food every time? So after this detailed history, we come to a conclusion that let's examine the child. So time for general physical examination. And when you think of examining a child for obesity, the first thing you notice is acanthosis. Is there any marker of insulin resistance? So acanthosis nigricans, they are the markers of insulin resistance. You also want to know if there is already a fatty liver, which is set in. The age and age-appropriate BP curves you are using to find out the status of blood pressure, because there are certain endocrine conditions which actually present with hypertension in a very young age. Then, of course, fundus examination to find out papilloedema. So these are certain basic general physical examination that you need to know. Now, one important question is, why do we insist on growth charting? Like, why did we talk of growth charting? How does that help? We are seeing already that the child is obese. So let's see how the growth charts help. Let's come to our second case. Now, she's Tanya, 8 years old, brought by mother saying that she has been diagnosed with thyroid. So somebody has gone for a thyroid profile testing and it came out to be, say, somewhere around TSH around 6.6. So thyroid test was done. Why? Because the parents felt that the child is putting on weight and it came out to be 6.6. What should have been done? Acanthosis, lipomastria, no goiter, mother on 25 micrograms of thyroxine. So that makes it like, okay, so the family history seems positive, though a 25 microgram of thyroxine does not make much sense. But okay, because the mother is already on thyroxine, the physician or the consultant thought that there is a positive family history. And it came out to be a subclinical hypothyroidism. So what do you think? Should we treat this girl for thyroid? She has acanthosis, she has lipomastria. And if you look at the growth charts, why the growth charts are important, we understand that as per the mid-parental height, the child is growing absolutely fine as the height is concerned. But if you look at the weight for height, which is much higher than the desired weight. As a result, do you think this child has hypothyroidism? Is hypothyroidism causing obesity, or is it the other way around? The overweight child and the obese child is having a subclinical hypothyroid. Does she warrant any further testing? I don't think so. We should focus on weight. So should she be treated with thyroxine? Absolutely not. But just for a word of precaution and ruling out, she must have been tested for anti-TPO antibody. And though it may be negative, if it is negative, fair enough, we can just focus on obesity. But if anti-TPO antibody comes out to be positive, then yes, we might think of treating the child for hypothyroidism also, besides focusing on weight. So anti-TPO comes out to be negative, TSH is 6.6, the time for diet and lifestyle modification. The child is followed up after 6 months and it comes out to be euthyroid. So now why do we use growth charts significantly? Because if it is nutritional obesity, it will be obesity with tall stature. The child is always taller than the remaining peer group of the same age and gender if it is nutritional obesity. If there is obesity with short stature, because height is the first thing to get stunted. So if it is obesity with short stature, then most likely we are dealing with endocrine obesity. If it is obesity with poor growth velocity, again, we are dealing with endocrine obesity. If it is obesity with delayed bone age, then yes, once again, we will think of endocrine obesity, that is hypothyroid obesity or GHD, or even hypothalamic obesity. So obesity plus height below 3rd percentile, it can be hypothyroidism. Obesity with a growth velocity less than 25th centile. Obesity with precocity or delayed puberty or arrested puberty, that is puberty has set in but not progressed for the next 5 years. Or obesity with delayed bone age. Or obesity with any focal deficit, then we think of endocrine obesity. Otherwise, it is nutritional obesity and we need to focus on diet and exercise. Next comes, we are also measuring waist-hip ratio. why are we measuring waist-hip ratio and what are the cutoffs in children? So for making things simple, the waist-hip ratio, waist should always be half of your height, less than half of your height. And why is it important? It is important because of the YY paradox. So YY paradox was given by none other than our own C.S. Yajnik sir from Pune. And Dr. C.S. Yajnik, when he was a student himself, this is C.S. Yajnik himself, when he was a student himself, this is C.S. Yajnik. So when he was a student himself, he had a fellow, he's a colleague, who was exactly the same BMI, 22.3, and same age. But when a visceral fat assessment was done, he was found to have some 22% of the visceral fat as compared to his fellow colleague with only 9% of the visceral fat. And then came the concept of thin fat Indians or thin fat Asians. So we are the people who are having visceral adiposity or visceral fat. And that is why we keep on measuring the waist-hip ratio. The frontal belly, the belly potting, the pot belly, that is very specific for we Indians. And that is the focus of most of the metabolic complications. So we have specific age-wise cutoffs of the waist-hip ratios, and that we have the charts also. So these charts can be followed to find out whether the child is having the particular data where we want the child to be. So we can plot the charts, and if it is more than 70th percentile, then it is time to evaluate the child. Let's come to our third case. Now he is Viren, 7 years old male child. He has been presented with complaints of micropenis. And the parents are very concerned. Specifically, I'm sorry, but specifically the grandparents are very concerned that boy is not growing properly. And it is time to see the doctor. And when you examine the child, you find that there is significant fat, pubic fat accumulated. So the BMI above 95th centile for 95% for age and sex, acanthosis present, gynecomastia present. There are white stretch marks of obesity, features of secondary obesity, accelerated growth, hepatomegaly, pubertal state, and blood pressure. All these are the markers towards obesity-associated micropenis or just a hidden pseudo micropenis or embedded. The penile growth is actually embedded in the pubic fat. So this is, you look for the stretched penile length and you will find that the SPL is quite normal for age. And there is significant lipomastia. There is acanthosis. There are white stretch marks. So now comes the question that if the child comes to you, if the parents bring a child, or if you notice or diagnose pediatric obesity or a childhood overweight child, what are the basic tests? What do you want to look for when a child comes to you, a child or any adolescent? So we assess, number one, cardiometabolic risk factors. So besides the history taking, general physical examination, now the time for lab workup. So send a blood sample for blood glucose. You can even go for OGTT if you want, or you can go for HbA1c, lipid profile. Also assess for associated comorbidities which can be there along with obesity, the associated complications of obesity, that is NAFLD or the MASLD, which is a new term, that is metabolic associated steatotic liver disease. Or if it is a girl child, look for PCOS, take a history of PCOS. Hirsutism is very obvious and evident. Look for OSA, then slipped capital femoral epiphysis. Look for, also measure hypertension. Then there are certain cases where you need to look for the secondary causes, so where we need to individualize what tests we need to get done. If we are talking of metabolic syndrome, we must remember that 2 out of the 5 features like hypertension, increased waist circumference. So we are not looking for BMI here, we are looking for the WHR. Then low HDL, high TG. Again, we have not focused LDL. We want a low HDL and high TG and a high blood glucose, not serum insulin levels. So very specifically, these are the 5 criteria. And out of these, if 2 are positive, then we are dealing with metabolic syndrome. Common comorbidities that we discussed, that is MASLD or NAFLD, PCOD, hypertension, OSA, and SCFE. NAFLD, if you're talking of, focus on there are certain good gastroenterologists in the panel, so maybe they can give in their opinion after the talk. When it is NASH or NAFLD or MASL we are talking, we think of diet and exercise so far. No drug has actually shown very good results, but we have certain empirically drugs which are approved and we are using. One is pioglitazone, one is GLP-1 RA is showing very good results nowadays. So you treat with metformin or ursodeoxycholic acid. If the SGOTPT is significantly high, then of course more than twofold or more than threefold, treat, repeat LFTs, use metformin. In children, metformin can be used. GLP-1 RA, we have still no approval for usage in pediatric age group, but GLP-1 RA in adults have shown very good results. Then the remaining of the drugs like vitamin E or insulin sensitizers such as pioglitazone, they are not of much help. If it is a girl child and the girl is having irregular cycles, menstrual irregularities, that is, then there are symptoms of androgen excess such as hirsutism or musculoskeletal, the android obesity. There are markers of insulin resistance like acanthosis. Then accordingly, we treat by either with OCPs, even with spironolactone, finasteride, or even metformin, along with diet and exercise. As per the AAP guidelines, we will measure the blood pressure and then we will chart the blood pressure, the normograms for the normal weight children with emphasis on echo if required, emphasizing the ambulatory blood pressure monitoring because at times it is in the doctor's chamber, white coat hypertension is not unknown. Then we have lowered glucose, the lowered goals for primary hypertension in children. The targets are low and we need to repeat the BP monitoring. Now coming to the last part, besides all said and done, still there are cases which we will have a syndromic obesity, or whenever you look at the child, you immediately know that, no, this is not something very routine. So we need a genetic sampling in such cases. There are syndromic obesities, such as there is early onset obesity, history of consanguinity among parents. Then there's family history of extreme obesity. These are red flag signs where you're thinking of some syndromic obesities, such as Bardet-Biedl syndrome, Prader-Willi syndrome. You find features, look for specific features of hypotonia, the short fingers, especially the third finger is small. Then there is clitoromegaly, there is pubarchy, there will be specific squint in the child, polydactyly. So these are all pointers towards syndromic obesity. And in such children, you have to individualize for genetic sampling. So if there's delayed development, yes, there is a developmental delay, go for karyotyping. And if the karyotyping is like, if it says there is no developmental delay history, then you go for serum insulin or leptin levels. Leptin levels are not available as such in with us at Jaipur at least. So I'm not much aware of the serum leptin levels, but serum insulin and proinsulin levels you can get done. So if the karyotyping turns out to be positive, it can be Prader-Willi. If it is negative, it can be look for retinal dystrophy, photophobias, or nystagmus. If the serum leptin insulin levels, some of these measurements come out to be positive, looking for congenital leptin deficiencies, you have to go for some molecular level defects like POMC deficiency or MC4R, MC43. So, and then lastly, we have the Bardet-Biedl, Alstrom's, TUB deficiency, or we have Albright's hereditary osteodystrophies. Then comes the last question, can we manage these children? For syndromic children also, and for the nutritional obese children also, and for the endocrine obese children also. For the endocrine obese children, of course, the first thing is first, that is, we correct the underlying disorder. For the nutritionally obese children, the first line of management remains your lifestyle management. That is dietary interventions and physical activity. Now, when we talk of physical activity, schools and families have equal responsibility. The child is too young to take a decision and suddenly decide, okay, I am overweight, I'll start exercising. No, that will not happen. Families will have, the parents will have to become the role models. Schools will have to change their timetables and set up place and time for physical activity. then we doctors, we have the responsibility of adding some pharmacotherapies if required. So exercise, at least for children, 60 minutes of exercise every day. And of course, it cannot be a very routine exercise pattern. They have to be allowed a physical sport. So we actually motivate the parents and promote the children to join some physical sport like football, basketball, badminton, swimming, cycling. So children love to play, and that is a form of exercise, 1 hour every day, vigorous exercises. At the same time, some endurance exercises should also be undertaken to improve muscle strength. In terms of pharmacotherapy, if needed, you can target insulin resistance, hirsutism, dyslipidemia, and hypertension. So hypertension, if not responding, and if there are 2D cosigns of LVH, then of course you need to add ACE or ARB. For dyslipidemia, you might need statins or fenofibrates. For hirsute girls, yes, you can have OCPs and spironolactone. They can be added, even metformin and local or creams like fluoronethrin, all these things can be given to treat PCOD. For insulin resistance, you can use metformin and the latest drugs, that is tirzepatide or GLP-1RA, or a combination of the double incretins, that is GLP-GIP, or a triple incretin, that is GLP-GIP plus glucagon, which is very soon in the market. Mounjaro is already in the market. So anti-obesity drugs, we do not recommend usually in children. The only drug we are using in children at times, and that also after the age of 15, is metformin. In adults, yes, we are using very frequently drugs like orlistat or cetalestat. And specifically, as I'm saying, we are using drugs like GLP-1RAs and GIP, and a combination of GLP-1RA and GIP, which have even been approved by FDA for anti-obesity molecules. Then if there are some underlying cardiometabolic risk factors or cardiometabolic disorders, then they need to be attended. Finally, the last option is bariatric surgery. You can refer the child for bariatric surgery, but they are, again, morbidly obese children where we recommend a bariatric surgery. The choice of surgery remains with the surgeon and the family and the patients. And post-surgery also, children need lifelong medical and nutritional surveillance, especially because the absorption is affected. So the nutritional supplements will have to be continued for life. So better it is, let's prevent obesity. And when we talk of prevention, of course, the government plays a big role by taxing sugars, taxing sugar-sweetened beverages, and especially all the sweets, increasing the availability of playgrounds for children, making safe environment that children can play. Schools have to provide place for playing, time for playing, teachers for physical trainings, and they have to stop the fast food hubs in the schools. Families, again, have a big role because the meals are taken as combined meals are taken, and what parents eat, the children will eat. The parents have to become the role models, set examples by taking healthy diets, regular exercising. So there's a big role of everybody, all of us. So finally, the time that messages, catch them early, plot them meticulously, don't miss your growth charts, investigate them aggressively, medicate them judiciously, expect results minimally, and still, after doing everything, accept denials, and they will go shopping happily. So please don't get disappointed that after everything also, and you're doing everything, they didn't listen to you. If they come back, try again, start from the first line, catch them early. With that, I thank you all for being here, and I invite you all to attend Tie Up, that is a dedicated type 1 diabetes conclave happening in Jaipur, 7th and 8th of December. This conference will have a dedicated core science plenary lectures by international faculties. Then there is a forum for type 1 diabetes NGOs also for expressing themselves. We have kept some entertainment with education. So we have some activity stage play as type 1 ki adalat. We have a lot of workshops on insulin pumps, exercise in type 1. And we have CGMS, SMBG, nutritional workshops, dal roti ka sawal hai. We have poster presentations and quiz for the PGs. And we have various cross talks on all debatable and different cross topics. So with that, I thank Anupam sir once again and Kochar sir once again. Thank you so much. And the house is open for your opinions, sir.
Yeah.
Dr. Meenal, can I just ask a short question?
Please go ahead, sir.
Dr. Kochar, Dr. Meenal, how often do you have to, fall back on psychological support by a psychologist to look at these children, in with obesity, especially adolescents?
So there are a lot of problems in the adolescent obesity people because they don't want to accept that they're obese, number one. Number two is very difficult. They are they will not tolerate your message. So that's why it is important psychologists are many time involved. Because this you have to tell the psychologist what we are trying to do, why the counseling is required for some time, because they will not listen to, especially adolescent, obviously I'm talking. They will not listen to your advice. They will not listen to you. So many times this counseling does help them. When the counselor tells them that you will have all these issues, you will have diabetes, you will have complication, all that, they still start listening. So in psychology, I have taken many times psychologists help, especially this, very, very severe obesity people, children, because I know I cannot get bariatric surgery done in a 14-year-old child. So I take the help of a psychologist also in these cases. Can I add some points?
Yeah,
Yeah,
please,
please, sir.
please. Go ahead.
First point is that, as far as bariatric surgery and all these things, we metabolism, we hardly do it unless, we have a child who is at least more than 16 years, fully pivotal development, Tanner stage, 5, whether it's a girl or a boy, then only we think of doing a bariatric surgery in such patients. Or if the child has got Pickwinian syndrome or child has got such a severe form of, morbidity, then we think of. So that's not a very common thing to do bariatric surgery in the pediatric and adolescent group. Number one. Number two is that, we even if we get in the patients of thyroid, where there was one case, where we had the patient has hypothyroidism. So in those cases also, even if you have TUPO positive, there is no guideline in the childhood thyroid hypothyroid management where you start giving thyroxine medicine. You have to keep on following them, following them, following them. Many of these subclinical come back to normal after some follow-ups. So that is why you need to be sure. That is why they made a cutoff of 10. Even if your obese subclinical is having TPO positive, it is not, because there may many people in the population will be having antibodies positive without having hypothyroidism also. So that's why that is more for adults, not for the pediatric population. So you can do a TPO, but you will not need to say so that these children need more follow-up, the TPO positive ones. That means they are more prone going to later into hypothyroidism as compared to now. So that's another point which is there. So that's why I want to make clear that we should not be, starting medication unless we are got a definite value of TSS, at least 10. And that is, so therefore, this is just more a female child with goiter, a child with thyroid antibody are more prone to get future hypothyroidism. So these patients need more follow-up in the life, That is third thing. Now, as far as GLP-1, this concerned, we have published a paper already where we used GLP-1 in obesity. And initially we did with liraglutide. We are going to plan soon, publish one on oral semaglutide, although it is not FDA approved. Not FDA approved for liraglutide is already there. So we will be publishing very soon where we use semaglutide in the adolescent population and we got very good results. So that's another thing I wanted to comment on. And the fourth thing is that, you have to, lifestyle is easy to say, but the children don't do it. Hardly I've seen any child who have explained lifestyle, left him alone. He came back with 70, came back 76 kgs, 80 kgs. Then nobody does it. The parents are never involved in India because all these guidelines are USA and American and British guidelines. These are not Indian guidelines, what we are talking today. So that's why I think we have to make it very clear that awareness has to be made more of obesity, and more of the people should understand the complication which is going to occur and all these things instead of just talking lifestyle, crowd lifestyle. Nahi karte. No, I've not seen any child in my practice who just
This is what we are doing now. That is what we are saying. We have to talk, we have to educate, we have to make them aware. What else? We have to, guidelines are same for everybody. We in India have to follow, we have to educate more.
Yeah, I
Every
agree.
visit it has to be hammered. We don't have medicines to treat children, obese children. We are not using drugs very frequently, and
So
we don't want to use drugs. So what do we want to do? We want to do the LSM.
instead of making a child grow from 70 to 76 or 80
We
kg,
never do that, sir. We never do that. We allow them to grow at a stable weight and let them gain height.
no, I agree on this, but it is not happening now in the society actually. We do all this, we try our best, but it does
Then
not.
do what?
So that's why I'm trying to say that that's why the FDA has changed that guideline of using Orlistat after the age of 10 years. So not no more 14 years. After 10 years, you can
But
start.
Orlistat does not have much good clinical results. Orlistat has got hardly any clinical results. The weight loss with Orlistat is negligible.
So what is actually happening is Orlistat causes lot of stools with fat. So these kids get afraid. They start running off the school. Maybe I had to go and wash and pass in the in my school dress. So then they are afraid to eat more. So Orlistat is happening that way. It's more like psychos. This is helping, and then instead of the actual way. So there are a lot of studies going on Orlistat in pediatric population also, where they found results also. So that is there. Then, I don't know, but sometimes even the glycomate is helping some children who have insulin resistance.
Yes, metformin can be used for especially in the PCOD girls and adolescent girls, even in boys who are overeating, where the obesity, like it's because of the what do you call excessive appetite is there. In
Yeah,
all
so
those places, metformin is used.
uh, so we can use metformin in that, especially with insulin resistance. It's quite with
Yeah.
academic and all those things. So that's another thing. So these are 4 or 5 points I just wanted to mention.
Have you used semaglutide or any of the GLP-1 RAs in non-diabetic children, or you're talking of the diabetic children with obesity, sir?
So
Your
now
paper on GLP-1 RA is on the
let me make it very clear. In the pediatric and adolescent population, it's mostly type 1 diabetes. We hardly very few adolescent type 2 diabetes are there. So in there I am using, and I'm also using in non-diabetic. That's why I'm going to publish very soon in use of semaglutide in non-diabetic obese patient with BMI, this grade 2. So grade 2 means that if you see the Indian population, it is something between beyond 35. So they are using that. In fact, grade 3, this is grade 3. So that I have using, and I'm getting very good results, and I'm going to publish it very soon. The same thing happened when we used liraglutide. It was not approved and it became approved, FDA approved. So you never know, what may come. But it's like, it's we take always the consent of the patient, explain to them that these are the complications versus the giving of this drug. You think you're ready for it, go for it. So I have used it. Semaglutide, lot of adolescent pop. I have got maybe around
non
60 now.
non-diabetes adolescent obese.
Yes. And they're also see, as I told you, type 1 is diabetes more common. See, today in today's world, diabetes, we are talking about type 1, all of it. So they were asking type 2. I said, it is there. It's come recently after obesity become rampant. That's why type 2 has come. Otherwise, we hardly used to see type 2. 10 years back, maybe one case or two cases out of 100 cases we see, but now it's increasing. So that's why now there's therefore semaglutide. But even in the non-diabetic obesity, yes, very good results. All adolescents, 60, 75, 80 kgs, 14 years, 15 years, 16 years.
So,
Very
sir,
good.
you've gone to up to what doses in children, sir?
See, I started with 3 only, semaglutide, and I've gone up to 77, and in some kids I've gone to 14 also. People who are 100 kgs, 110 kgs.
Children 100 plus.
Yes.
Mhm.
You see the part of this area Muradabad is your that what is that place, there are 2 3 places in UP. We get all these kids are coming, they walk ta 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 ta, ta, they walk like Humpty Dumpty when they enter the clinic. Then you tell them all the things, lifestyle. After 4 times they come कि हम तो सर पहले 100 या 110 kg हो गए, आपका कोई फायदा नहीं हुआ, दवाई वाई कुछ फायदा नहीं हुआ, and then they want to go to another doctor, and then they say, so that's another thing. So you have to, I don't know, that I feel this has to be looked after.
Perfect, sir.
So Anupam, anything you want to add or subtract or anything?
Sorry, Dr. Kocher, can I ask you, any one of you can answer, but it's not related to obesity, but what is your take on newborn screening for hypothyroidism, where you get a borderline TSH? How will you handle that?
No, see, it's very simple. If you have a newborn with suspected hypothyroid, I mean, if you have a THS more than 20, in the first 2 weeks of life, you have to, retest it. If it has been a cord blood test, you have to retest it. If the value is more than 40, you can, think that the babies will definitely be hung up. But between 20 to 40, you can just, follow it up, that's all. But if the value is something like 80 or 60, above 60, then you might have to start immediately start and then follow up with later how things go. There are a lot of babies we start with, thyroxine around age 25 or 50, in fact. And then later on, after 6 months, you find everything is going however. TS is going less than 0.1, this thing. So it's many times it is seen like that. But you have to follow up these babies. So screening is okay, but with after screening, there is a clear-cut data that TS is more than 20 after with the first 2 weeks, and TS is more than 10 in the after 2 weeks. This you need to start working on these patients as far as hypothyroidism is concerned.
Okay. Can I ask you a corollary to that question is that if you have a TSH round, say 12 or 13, how
Mm.
will you tackle that patient? What will you do?
What is the age?
And
Age,
this
Age
age,
group,
is
sir.
a newborn screening in which you get a TSH of 12, 13 or so.
what is
Sir,
the age? Newborn screening,
weaker, sir. How much weaker? Yeah, what weak?
Say a term weaker, a term for that matter.
so term for nothing, I will do nothing. Maybe if I want, if I feel, I might repeat after 4 weeks and then decide. But I will not give anything in the first time.
Okay. And if at 4 weeks you get 14 again, 13, 14 again, then what will you do?
Oh, then I think I start, low doses of thyroxine stuff, because this is the guidelines is more than 2 weeks, more than 10. It's more than 2 weeks, is 4 weeks, is more than 10. I will start.
Okay. Thank you.
But
Thank you,
see,
sir.
Anupam,
There
but
is,
very important, Anupam, is follow up with these babies.
yeah,
There are
yeah,
many
yeah.
times
The
because
trend is important, sir. If it is showing a rising trend anyways, or if it is stable at the 12, 13, 14 after 4 weeks also, then you have to treat.
yeah.
Okay.
So second
There's a question in the Q&A. Are there any side effects of weight training in young age groups?
side effects of what?
The
Weight training.
rigorous, yeah, the weight training, sir.
Training means. See, I think the law is that any person less than 18 should not go to the gym. That's what they do in all countries like USA and UK. India is the only country where 10 साल का बच्चा gym कर रहा है. So I think that has to be taken care of first. They can be trained to there are good trainers now in India who are training the kids and adolescents to what exercise should we do, what exercise will help them. So these they can be taught, but going to gym is not be there for less than 18 years.
That is why we talk of allowing them to play, sir. Because we don't want a
Hey, hey,
rigorous
कुछ भी खेलो,
programmed training.
हॉकी खेलो, फुटबॉल खेलो, बास्केटबॉल खेलो.
Because we don't want the programmed or what you call the structured training is not recommended below 18.
Any other questions? There are none in the chat box or in the Q&A. Kochar, anything else you would like to add? Otherwise, we'll wind it up.
So I think Meenakshi did well. And second thing is that I already told about the TPO and all these drugs and all that. So bariatric surgery, please do not put in mind the kids and adolescents. Tell them to wait, because this has recently been putting into a lot of kids. They come to me and tell me that bariatric surgery kara le, bariatric surgery kara do. So I think that has to be tackled well. That it's wrongly being put into these people's mind. Unless they are fully mature, your Tanner scoring is 5, you are more than 16 years, never think of bariatric surgery. There are some cases in China they have done, they were published also, that this tip that, but that was a case of Pickwinian syndrome. So you have to be careful when you decide bariatric surgery, this thing. And I think it's very clear the guidelines, 16 saal se upar, Tanner se BMI at least more than 40 or BMI more than 35 with comorbidities. If the patient of, the boy of 16 years, he's got hypertension, he has diabetes, yes, you can think of bariatric surgery. But as such, because obese without this thing, no need for bariatric surgery. So that has to be
Now,
taken.
now with the coming of the double incretins, the tirzepatide is also in the market, sir, now. So we'll have more medicines to treat. So hardly we will require a bariatric.
as tetracycline, I've already started using it. But I think, we have to be very careful in using in the pediatric and adolescent
In
population.
pediatric age group, we don't still have the recommendations anyways, sir.
We have to be very careful. I've got it from, Abu Dhabi for some patient, but, basically, I think we have to be a little careful because there's still, not many, follow-ups and further we need more studies and more, time to understand what this molecule is going to do for these people.
Okay, thank you very much, Dr. Meenal, for an excellent talk, overview of obesity, and Dr. Kocher for a great review and your special comments. I'm happy that we've been able to deal with such a vast subject in a very nice way. Thank you, both of you, and thank you, audience, for being there with us. And good night, everybody. Thank
Yeah.
you, sir.
Thank you so
Thanks,
much.
Anupam. Thanks,
Good
Anupam.